Good afternoon, everyone. This is Andrea Height with Derby Dental. Welcome to our second in our DSO Micro MBA series of presentations. We are really excited to be able to offer these to you. And today we're going to be focusing on partnering with payers for mutual success. That is the title of our webinar today. So let's do some introductions and we will move things along. So firstly, we've got two sponsors for this webinar today. One is CareStack. CareStack is a cloud-based enterprise solution for DSOs especially, although it works in multiple situations. But it brings all sites together on a centralized platform. So we're very excited to be partnered with CareStack. Then, of course, we have got Derby ourselves. We have got a new DSO team. We focus very much on solutions for DSOs, not just supplies, but all of those different challenges that we're seeing DSOs face, especially in this very changing and dynamic environment. So now to get on to our WebEx for today, I'd like you to meet our experts. Firstly, we have the wonderful Miss Amy Marco, who is a consultant and owner of Amy Marco and Associates. She has got a broad set of experiences from working with large national insurance carriers, managing P&L accountability, creating multi-year strategic plans, building national provider networks. She's got extensive operations management, sales, networking, and general business expertise. But of particular resonance today for this meeting, her involvement with insurance plans, having served in areas where she's had to negotiate partnerships with payers and served on the board of the National Association of Dental Plans, the California Association of Dental Plans, and as the past chair of the Oregon Health Coalition. She brings a wealth of experience. She also was awarded the National Association of Dental Plans Gabriel Award, the association's Lifetime Achievement Award, and their highest honor, which is just pretty amazing to me. And then I have a fellow Australian, Dr. Hendrik Bly, who is co-founder and principal consultant for Sage Dental Consulting. He's going to be our moderator today, and I'm equally excited to have you meet him. We actually both attended the same dental school in Australia, except it was in different decades. So, but absolutely thrilled to get going. And so, Hendrik, I would like to turn it over to you and we will be off to the races.
Perfect. Thank you so much for that very, very warm introduction of the panel, Andrea. And now as we move forward through this payer mix, I'd like to, with an understanding that we have a fairly broad mix of attendees, people that are frontline employees dealing with insurance on a day-to-day basis, through to sort of C-suite RCM VPs that are making strategic decisions around insurance and payer relations. I sort of want to begin at the basics, just so we can give a reminder of the fundamentals of dental insurance and what it looks like. And certainly things that are like premiums and how to fee schedules, the difference between ASO, fully insured, and how supply and demand impacts the dental industry. So one of the questions I often get asked by my clients is, hey, insurance companies are raking in all these massive premium dollars, but where does the money go? Because there never seems to be enough money to pay premiums. And of interest is that when we look at how the business costs for insurers work, is that there is a certain amount of money that goes to the brokers, which promote the insurance carriers. There's a certain amount of money that goes to pay taxes. There's a certain amount of money that goes to pay management expenses to run the business. And then there's a certain bucket of money that's used to actually pay claims. So of the sort of those buckets, we expect about 6 to 10% of premium dollars to be paid out to the brokers. So that sort of accounts for a fairly decent chunk of premium revenue. And then under the Affordable Care Act, I guess, fully insured plans, standalone plans, including dental plans, are taxed 3% of their total premium revenue. So there's a fairly decent chunk of premium revenue that goes to tax. And then in terms of the cost of operating the business, so there is a bit of a range here, but it ranges from about 9% in some smaller states like New Hampshire, up to some larger states like California, where we've got expense ratios of maybe 18%. What that basically then leaves us is about 76% of our premium dollar revenue available to pay claims. So that 76% is what's referred to as a dental loss ratio. And that's a 76% sort of national average. In some states, that dental loss ratio is significantly higher. So we're looking at maybe 82% in states like Washington State, to a super low percentage in California of about 61%. So that sort of just gives a little bit of a breakdown as to where the money is actually flowing to. So if we sort of begin to add up a few of those buckets, it sort of indicates there's not a lot of sort of profit left over in terms of percentage of top line revenue for dental insurance companies. So that's sort of just a bit of a background as to where the money flows in terms of dental insurance companies and the payers. And knowing that only 76% of premium dollars is available to pay for benefits, that's sort of where that initial sort of fee setting comes into play. So what's your experience been on that, Amy?
Again, to your point, you described it very accurately. And looking at, where does the money come from and how is it dispersed? I always used to think that the actuaries and underwriters just kind of pulled numbers out of thin air because they look pretty good. In some cases it may be, but what happens is it's looking at the plan designs and then setting those premiums. And what insurance carriers do is that they look at how the plan is going to operate. So they won't write a plan without asking for 2 years worth of utilization. So they can see how the plan is operating, how the employees are utilizing. They also look at fair health data. And some of you may have heard of that organization. And what that means is that mostly at least all of the major insurance carriers will send all of their claims data to Fair Health. Fair Health will then look at that data and they will break it out by CDT code and then by 3-digit GeoZip. So if you hear, for example, that you're being paid at the 70th percentile, it's not percentage, but the percentile. And what that means is that 30% of the dentists in your market have higher fees than you do, and 70% are either where you are or below. So it kind of gauges where you are in the market. So looking at the Fair Health data, the insurance carriers will look at the average as how claims are being paid, looking at UCRs. They'll look at utilization data. And they'll come out with, to your point, between a 76% and an 80% loss ratio. So that's 76 to 80% goes into care delivery. It's all specialty claims. It's out of network. It's your fee schedule if you're a GP. It's the claims examiners. It's the systems that pay the claims. The rest is for profit, for, as Hedrick said, for brokers, for advertisement, for putting the plans together. So that's how the insurance carriers look at things and how they actually come up with, what's the premium going to be. It also depends on the type of coverage.
Mhm.
And Hendrik, you touched on that as well in your opening, is that it's very different from a fully insured client to an ASO or self-funded client. So a fully insured client will put out to the insurance carrier the type of plan they're looking to install, what percentage of the costs they want their employees to share by co-payment. What does the plan look like? What does major services look like? And then the insurance carrier will then go back, look at those 2 years worth of claims utilization, assume that there's not going to be a change in that utilization. And based on that, we'll set a premium, $100+ a month. The insurance carriers pays that each and every month the contract is in effect. And the full risk of that plan now sits with the insurance carrier. If utilization changes, if they overestimate it or underestimate, it sits with them. The difference when you're an ASO, which is administrative services only or self-funded client, is that the employer maintains the risk for the dental. So what that means is the same thing. The insurance carriers will do all of the analysis on the 2 years of utilization, look at all of the same information, fair health, and then go back to the client. And that client now will hire the insurance carrier to administrate the plan. So the insurance carrier now looks like a TPA, a third-party administrator, where they're paying the claims, they're answering the customer service phones. The difference is that in a fully insured, the insurance carriers are getting $100+ a month per member versus $4 to $10 per month per member to administrate. Where the risk lies, and when I talk to dentists and I work with dentists, they say you got to go back and get me higher fees. And as you know, most of you have been there, most of you have asked, and most of you heard the word no. And what's happening is that I don't know of any carrier that will write a client without giving them a minimum of a 2-year rate guarantee. So again, looking at past utilization, projecting that utilization forward, saying we believe that we're going to give you this rate today, and that rate will be in effect for 2 years. So even if I'm sorry, Hendrik, go ahead.
No, go ahead. I think it's a great point you're making there.
Yeah. So even if, in fact, they said, we'd like to give all the dentists an increase, they can't go back to that client for more money, and that's who's paying the bill. And again, they only have so much reserves that they keep, that banks on utilization changing. To further complicate matters, COVID has had just a horrible effect on everything. When all of our offices were closed and our patients couldn't come in, all of that premium accumulated. And so what we're seeing now is that the insurance carriers either return the premium for that year period, or they've extended that rate guarantee. So what was 2 years for them to go in and ask for additional premium now looks more like 5 and 6. Regardless of what happens in the environment, they're going to be unable to go back and to get that to any kind of premium increase because there's just no more excess dollars. And if you look at the slides, the bottom line is it really is simple economics. And it boils down to supply and demand. When you look at an employer comes to an insurance carrier and wants a proposal. How they evaluate a network is they look at access points. So they will give you all of the zip codes of all their employees. We look at where the dentists are, and acceptable access in an urban environment is 2 active open providers within 5 miles. And so if they have that access and the networks are competitive with each other, there really is no reason to go out and spend more for what they already have. And, I think a good example today is, we're having an oil crisis. The supply of oil is low, and we're all paying $5+ a gallon for gas. Right now, these networks are saturated. If you look at some of the statistics, we've seen at least a 10% jump in providers participating in networks. So the networks are saturated. There's not any holes to fill. So if there's no demand for additional providers in a given area, the supply of reimbursement is diminished. Where there still is a gap, and we could talk a little bit later how that can help you, is specialty care. There are still major holes. There's still insurance carriers very willing to work with providers and groups on specialty.
Well, yeah, I think those are really good points there, Amy. And I think, in addition to the simple economics and sort of the macro view that we've been talking about supply and demand, and then, raw utilization, there are certainly some provider specific sort of things that payers look at in setting fee schedules. So there are some concepts that sort of overlay the macro sort of aspects that Amy has touched on there, like this pay for performance model, where Delta Dental is one that specifically does this. And I think it was Delta Dental of Minnesota that sort of pioneered this whole thing, where they used their utilization review data to stratify providers according to what they called preferred behavior. So you would be considered a good performer or be exhibiting preferred behavior if your insurance utilization data was aligned with what Delta Dental of Minnesota in this particular case felt was good quality comprehensive care. And if you were seen to be exhibiting good behavior, your fee schedules would increase. By the same token, if the utilization review data indicated that you were an outlier compared to the other service providers in your area, you would actually have your fee schedule frozen, or you may even be removed from the network. So I think in addition to some of those broader, simple economic supply and demand and macro factors, just be aware that there is a constant utilization review that the payers are doing at a provider-based level as well, which impacts the fee schedules that are provided to different providers. Has that been your experience as well, Amy?
It has, and there have been, as you said, Delta taking the lead. And so looking at across other insurance carriers, and my most recent experience is, how do you move from a transition from fee-for-service payment as we have today to moving over without disrupting your network and without disrupting your members and your clients? And then how do you truly make sure that you have the right data so that when you're looking at a provider on the top end or the bottom end, that's truly where that doctor belongs?
For sure.
So it's being talked about. It's been talked about. It's been on many strategic plans that I've seen, but it hasn't gotten the same foothold. And I think what may happen is that waiting for more of the results coming out of Delta to say, what was the network disruption? What was the customer satisfaction? And is this something that there is true value in moving to?
Absolutely. And I also wanted to touch on something you mentioned about the ASO, what an ASO is in terms of the administrative services only. So sometimes our audience might see something called an ASC, which is an administrative services contract, which is very similar to an ASO. The only difference being that the payment actually will come out. So claims payment will actually come out of a bank account owned by the insurer, and then the insurer will seek reimbursement from the employer rather than the employer having to pay the claim directly. So that's just in terms of something you might see. The ASO and ASC are effectively the same, but it just adds another step to the process.
Yep. And what happens is they'll pay claims in what they call batches. And every night there's a batch. That batch gets dollar value gets sent to the employer. The employer funds the insurance carrier's bank account. Once the funding hits, the claims are paid.
Yes, that's absolutely great point, great clarification on that. And the reason I think it's important to bring it up is because we're actually seeing an increase in the number of ASOs and ASCs in the market. I think there was, especially with the ACA coming into effect, where standalone fully insured dental plans have to comply with ACA requirements, whereas ASOs and ASCs don't. So the compliance costs are typically a lot lower. We're typically seeing about a 1 to 2% increase in ASOs and ASCs every year. And we're currently sitting at about 60% of the dental plan market is being comprised of ASOs and ASCs. So it's something you're going to see more often as you sort of engage more with payers. So
absolutely.
definitely.
And over the last probably 5 years, that trend and those numbers have doubled and tripled. And it used to be where an insurance carrier wouldn't write an ASO count for less than 5 to 10,000 employees. They're now taking on ASO clients that have 100 employees or less. So I think employers are becoming better understand the process and looking at utilization patterns and how little they've changed, are better able to budget, which is what it's all about. And therefore they feel a lot more comfortable taking that risk on themselves than passing it on to the insurance company.
Yeah, absolutely. And that's not to say that, fully insured is going away anytime soon. There's still a significant portion of the market that is comprised of the fully insured standalone dental plans. And I guess, that sort of is probably a really good lead into what are the different types of plans under that, particularly that fully insured model. I think we're all pretty familiar with the PPO model and the dental HMO model. And
if we can go to the next slide, we can just kind of, or no, the one before that, I think. The one with the, looks like a martini glass. You could tell where my head was when I put this together.
No,
Is there one missing?
this was all I had.
Okay, well, we could talk through it. So all it was a martini glass with lots of olives in it, or actually bubbles. And each one of the bubbles had a different kind of a plan. And there's just so many types out there. So if we take, quickly kind of walk through those that had the highest reimbursement level to a provider, to those plans that have, minimal reimbursement or low, it's the indemnity plan, which before insurance came into play and all these fancy plans came out. Indemnity it looks very similar to UCR, maybe very small reductions, very similar to Delta Premier, where you're getting maybe 5% off of your average UCR. There's no network. Patients can go anywhere they want, pay out of pocket, or the insurance carrier reimburses. Those plans have been losing members over the last 15, 20 years in triple digits. No one has insurance and no one's writing indemnity. And even Delta, in order to be a premier doctor, you have to accept their PPO plan. They're no longer just putting together their premier network. If you go down the next level, another plan you may hear of is direct reimbursement. And again, this is in the same kind of place where, pay for performance and those quality type plans is direct reimbursement has just never been able to take a strong hold. And direct reimbursement there really is no network. It's where the employee at the point of service, they'll go in and get the work done that they need with any provider they want. The employer will then reimburse the employee. And so it's easy for the employer because they can budget. Once that employee reaches a max, then there is no more coverage. Again, this is a plan that's been out there for a long time, but has never really taken traction with employers. Going down, you may hear about your discount plans. Discount plans were really designed, it looks and walks like a PPO, but they were basically designed for individuals who were looking for comprehensive dental plans. But because you're not with a group, they're either premiums are out of sight and out of control, or if you retired, you had dental and you want to continue dental. So a discount plan basically is a PPO with a similar discount. And most of the insurance companies that are selling discount plans, it's being sold to very small groups under 5 or to individuals. If we come down, again, the most popular, and I'm sure what you all know and have in your offices, is a PPO plan. And this is where the employer comes in and makes a decision on what type of benefits do they want to offer. Typically, what you'll see is 180/50, where the insurance pays 100% of basic, preventative, 50% for major. We've seen 100/100/0. There's 150/40. They can put it together any way that they want. And then you're paid based on the split between what the insurance pays and what the member pays. Typically, what you'll see on the market when you're signing up for a PPO plan, the average is about 40% below an average UCR. Is what those plans are coming in, and how you're reimbursed. And those are the plans that you are most likely talking about when you're going back to renegotiate contracts, are your PPO plans with the carriers. Go down a little bit further as far as reimbursement. There's the direct point of service plan. There's the either executive or all kinds of PPO plans. And that's where it's a very small network. And employees get a much better benefit. By going to that network is that they have less out of pocket than going to the general PPO network. So sometimes an employer will offer 2 networks, very tight network, which is your EPO. So if you go in and stay within that small network, again, less out of pocket versus the larger PPO network that they have. There's some of that around, again, not something that's been taking a great big hold. The next plan that I'm sure you've been approached with by insurance carriers is Medicare Advantage. These Medicare Advantage plans, when you look at all of the analysis and all of the analytics out there, is going to be the fastest growing dental membership plan over the next 2 years. And so a lot of doctors that I talked to said, I don't want Medicare, I don't want Medicaid, I don't want government programs. Be very careful. Medicare Advantage is not a government program. It's, and I'm sure we've all seen them on TV, these Advantage plans. When you retire, you buy an Advantage plan that has more coverage than just the Medicare that comes from the government. They're now offering comprehensive dental plans. So when those plans hit your office, they walk and talk and pay just like a PPO. So they could be really good ads to your office. So don't shy away because you hear Medicare. Make sure to ask the right questions about whether it's a Medicare Advantage plan, or sometimes there are some Medicare plans, very, very limited coverage, very, very limited reimbursement. And we'll get more into when we talk about how to kind of improve revenue and increase patient flow. We'll talk more about these types of plans. Coming further down that scale, less reimbursement is what you've heard of as a DHMO or DMO, Dental Health Maintenance Organization or Managed Care Plan. This is where, again, it's a very tight network, and members have a copay. So there's no claims, there's no reimbursement, so to speak, on a procedural basis from the insurance company. So, but you do receive a capitation. And what that capitation is that in order to receive benefits, those members have to select a provider from the list. Once they select your office, their name goes on a roster. You get that roster every month. Everyone who's on your roster, you will get paid a capitation per member per month. Those capitation dollars range between $4 and $10. So that member never needs to come into your office. You still get the capitation. When they do come in, there's a low out-of-pocket copay that they pay for services. And that typically is about a 50%, maybe sometimes a little higher discount off of your average UCR. And then, of course, the last plan, as far as the lowest paying plan, is Medicaid. That is definitely a direct government, even though there are organizations that administer it. That is a government plan. Not as comprehensive in most cases, lots of red tape, of what's covered, what's not covered, and very low reimbursing. So if you look at the kind of the array of plans that are coming in your office, they all have fancy marketing names. Everybody calls them something different, but those are the kinds of the basic plans that you're probably seeing from network recruiters that are coming in, talking to you about joining their plans. So, if we go to the slide that we have up now is, how do you know which one is right for you? The one before that, that's the one. Thank you.
There we
So
go.
just before you get to that, Amy, I would also sort of say that, I wanted to mention to our audience, although it's not a specific kind of plan, it's something called a PPS reimbursement model, which is typically seen in Medicaid accepting federally qualified health clinics or federally qualified health clinic lookalikes or things like that. And while, typically most dental offices won't be able to participate directly in this prospective payer scheme or PPS model, they might be able to partner with organizations that do. And the benefit of a PPS reimbursement model is that it's not reimbursing on the actual items performed, it's reimbursed per encounter. So anytime you see a patient that is reimbursed under this model, you're paid a fixed amount, doesn't matter how much work or how little work you do. So some of these FQHCs do partner with dental organizations, be they small DSOs, single doctor locations, to provide dental services through this prospective payer scheme reimbursement model. So while you may not be able to participate directly in it, you may be approached at some stage by an FQHC or sort of Indian Health or Tribal Health or an FQHC lookalike, and asked, would you like to participate in providing dental services under this prospective payer scheme, which is done through the Medicaid model in each state. So just wanted to put that out there. It's not completely common, but it's common enough, certainly with my clients, that seen it a good handful of times. So just wanted our audience to be aware of that PPS model.
Great, thank you.
Amy, I've got a question for you because you mentioned capitation, which in my experience can be a double-edged sword depending on how it's structured, depending on how patients are enrolled and so on. I don't want to jump the gun on the order in which you're going to be discussing things, but would you mind working in a little bit of a discussion on things to be aware of, things to consider when enrolling in a capitation plan to make sure that it works for the provider?
Yes, thank you, Andrew. I think, what you look for primarily is look at how far you're booking out right now. Also look at your empty chair time. And then to make sure that you manage, what a capitation plan will do is, if you're looking to fill chair time, because remember, you may not have a patient in that chair, but your hygienist still needs to get paid, the electric bill still comes in once a month, is that by putting a managed care plan in and getting the capitation every month, it helps offset some of your expenses so that your chair time can now be filled with the more lucrative PPO, indemnity, DPOS plans that are coming in. Mm-hmm. What you need to watch out for is you want to make sure you have a very healthy balance. So I would recommend that, maybe no more than 30% or 35% of your practice are DHMO plans. And again, because you don't want that overpowering. And also look at, the number of patients that come in. If you only have 3 people you're getting capitated for, and you get $15, and someone comes in with a $2,000 treatment plan that they're going to give you another $200 for, that's not how you want to work with managed care. So one of the things to look at is, I've always, talked to the insurance carriers. It's very important, and with any plan, is to ask what their membership looks like in your market. Don't look at it by state, because, again, if they say we have 100,000 people in Nevada. Your offices are in Reno, but there's only, 900 people in Reno, but there are 25 providers in the network. That money's being diluted. And so for capitation, it's important to either, talk about negotiating cap factors, which is a higher cap rate, minimum enrollment. And what that means is that, let's say you need 50 people a month for that balance to break even, to make up for those people coming in and utilizing the plan, is you can negotiate a minimum cap, a minimum membership of 50. What that does is that it gives you that even though there's only 5 people, they'll pay you for the 50. What it does for the insurance company, it's not a supplemental payment that's there forever, right? Is that as your office builds to 50, then it's break even for them and they're paying. So it's looking at, volume on capitation, and what you're looking, and how you're looking to manage that in your office.
That's a great point. And I think another point that, I think people need to look into is that there's not just one capitation across the board. You can have something called global capitation, where everything is sort of capitated, all services, and then limited capitation, which has, much more restricted number of services that are covered under that capitation scheme, which means that there might be some scope for, non-covered services to be paid for out of pocket, or effectively in a fee-for-service model. So I think it's important to sort of not only think about the balances, as Amy said, but the type of capitation schemes that you're looking to implement. Obviously, global capitation can be challenging in terms of profitability, just because of the full scope that it covers. But I think that's another factor that needs to be thought about.
Mm-hmm. And if we could go to the slide after this one.
Yes.
Please. Did I answer your question, Andrea? I don't want to move on without.
I was going to ask one more question, because one of my thoughts is, I would assume you've got to look at how an insurance carrier assigns a capitated patient. For instance, if they only assign them when that patient is seeking care, then you've got a problem. You've got to have a random enrollment of people that are enrolled in that insurance assigned to you, regardless of whether or not they've requested a dentist.
So how that works is, at the time the employer has their open enrollment, the time all of the employees go in and select, let's say they want a PPO or DHMO. If they select a DHMO at that time, they're required on that enrollment form to select a provider. And they become eligible with that provider the first of the month. So let's assume that people are like me and I skip over forms and I forgot to put in a provider. 3 months now go by. I'm not on anyone's capitation list, but now I need to see the dentist. So what will happen is the insurance company will put that member on your list, but they will pay you from that member's date of eligibility. So if I was eligible in January, but I didn't select a provider until March, then what you will see is the March capitation on your roster, and you'll see 2 months worth of retroactivity. So you will get paid for that. If a member wants to go somewhere else, they have to call the insurance carrier, select a new provider, and then they'll come off your roster. And nothing happens in the middle of the month, so there's no proration. You're eligible at your new doctor the first of the month following your request. And so people will be coming in and going out, but always, to your point, Andrea, is they will give you retroactive capitation from the date of eligibility.
Good, thank you.
I think that's really great information there. And I think, as we talked about the kind of plans, and now it's, how do we select the best plan for our organization, with so many options. So in your experience, what's the process that you would go through in recommending a plan, or how to evaluate plans to implement or bring onto any kind of organization, Amy?
I would get an idea of what my threshold is in my office. And how I look at threshold is, if I take, utilization of all my insurance carriers along with the reimbursement, and say, I'm going to make this up, that my threshold is of all of the carriers that I'm working with on a PPO basis, that I'm at 49% of UCR. So that's a threshold for all the carriers I'm working with. So as would I look at a carrier coming in at 30% of UCR? I wouldn't, because so as long as someone's around that threshold, then I think that they would fit into the practice. The other thing is, don't just look at, providers have a tendency, and when I was working on the provider side, I did this myself, was I'd go pull out crowns, I'd pull out bridges, I'd pull out certain procedures and look and just base it on that one copay. I would always go in, and it's really good to know, what are your top 30 procedures in your office? Mm-hmm. And I would bet you that if you did that, you would find that those 30 procedures are generating 85+% of your revenue. So I would take a look at that top 30, maybe in your case, it might be 50 or it might be 40. And that's where you should evaluate your fee schedule. I always laugh and say the one procedure code that back in the day when I started in dental that always made me laugh was a frenectomy. Mm-hmm. So if you're not doing a lot of frenectomies, it really doesn't matter what they're paying you on a frenectomy, but look at those top 30 that are generating the revenue. And that's where you focus. If you find that you're getting overwhelmed and someone's, you're booking out more than 2 weeks, 3 weeks, you're booking a month out, mm-hmm. And someone comes in with a fairly decent plan, do you want to add on or do you want to kind of replace? I always look at your plans, because remember, every time you take on a new plan, it's putting it into your practice management system. It's training your staff. It's calling more eligibility, calling for more pre-authorizations. And if it's generating one chair visit a month, is it worth it? So look at your carriers, look at the bottom to say, if I want to bring in this new plan, which has a higher reimbursement, do I need to keep the bottom? But I will caution you that I've worked with a lot of doctors. The first thing they say to me is, terminate that plan. They're not paying me enough. Mm-hmm. Right. And then looking at the schedule. Well, if that's bringing you $200,000-$300,000 a year, before you send in any termination letter, make sure you have a plan on how you're going to replace that revenue. Right. So there's nothing there that's saying your other plans are going to be putting more people in the chair. So just make sure that you have a plan to replace that revenue before you just send out a termination letter. And then again, look at, make sure you understand, it's not just that fee schedule. Make sure you understand the plan. Where I would go look is there's always what they call exclusions and limitations. Exclusions are those things that are not covered. If there's something in the exclusion, it doesn't mean that you can't do the procedure, it just means you're not getting paid for it by the insurance carrier. It does mean you can charge usual and customary if the member wants that procedure done and you work that treatment plan. Understand your limitations. And a lot of times what providers don't understand is there's a big difference between coverage. If you have your pro fees, whether your pro fees are paid once every 6 months or it's coverage for 2 a year. Because if it's once every 6 months and you do that second pro fee in 5 months, they're going to deny the claim. If pro fees are covered just at 2 a year, you can do one in January, one in February, and it'll get paid. So understand the language and how it's written, just to make sure that you're not shorting yourself on your claim. Through your local dental associations, understand some of the regulations that really affect your bottom line. 2 that I can think of. One is the Non-Covered Services Act. Is if you look at some of your old PPO contracts, there's going to be language in there that says, even though a procedure is not covered, that they asked you to do the procedure for the patient, but do it under the PPO reimbursement. That contract language is no longer valid. I would say just about every state passed what they call non-covered services. And if the service that you're rendering is not on your list of your schedule, as a covered benefit, you have the right to charge your UCR. The insurance carriers can't tell you what to charge for non-covered fees.
Mhm.
And then I think,
in terms of like a benchmark of, what a payer reimburses versus your UCR, what would you say is an absolute basement that people should be, or our audience should be looking at for maybe knocking out a plan or reconsidering whether to participate in that plan? Would you say 30% or 50%? What in your experience, what's your?
I would say in the 30s, but I would say, look at the plan. If it's reimbursing at 30%, but you have high volume and high utilization, then that's a plan you really need to sit down with the insurance carrier and negotiate. Because again, if you're running that many patients through your office, they don't want the noise of having to lose a doctor. So those are the plans that you might be able to negotiate. If you have a plan that's your threshold at 49, plans coming in at 32, no, very little volume, then again, that might be a plan I would replace if something comes in that, there's a lot of new Medicare Advantage plans coming out on the market with some very good reimbursement. So, and the other thing that I would make sure that you understand is that two things is one, there's new prompt pay laws. And what that means is that for every clean claim, and we'll talk about clean claims in a minute, every clean claim is that the insurance carriers must pay you within 30 days of receipt of that claim, or they have to pay interest. So, when you're tracking your claims, if your claim was clean, in other words, you had everything correct on it, then you can collect interest. And then the other thing that is so important is I talk to a lot of doctors who, when they bill the claim, will bill the allowable. So if their UCR is 100, but the allowable is 70, they'll put $70 on the claim. Always bill your UCR fee. One, it helps when you have to collect payment from the patient. And two, the insurance company use those claims to look at average UCR, and you're hurting yourself by showing the 70 and not the 100.
Absolutely. I think it's a great point. And on that, I think it's really good practice to sort of understand how often your insurance companies or your payers are adjusting their reimbursement schedules. Most do it once a year, some do it twice a year. And
they're not doing that at all.
Oh,
it used to be once a year, then it went to twice a year. And now I have clients that I'm working with that the last increase they got was 2018, and carriers are refusing to increase. So there's no more rules. There used to be, Hendrik, but they're gone. And so what I want to do is just, if we can go to that last slide, real quick, is what can you do with all of these moving parts and things you can't control, right? You can't control that you're not going to get that fee increase. What can you do? And so, looking at what the arrow will start where it says clean claims, is make sure that the claims are being billed properly. Make sure that you're using the right codes. Don't use surgical extractions when it's a simple extraction. Make sure the doctor who treated the patient is who signs the claim, that all of the information on that claim is accurate. What that means is that it'll be auto adjudicated. That means nobody's going to touch it. If it comes in, the system reads it, it's clean. It'll go right through auto adjudication and you get paid much sooner. If it drops, you have to wait till a claims examiner gets it. They have to pick up the phone and call you and say the person's address is missing or their membership number is missing. And you have to keep going back and doing this. The more an insurance examiner holds that claim, the more they're going to look at it, diagnose it, and say, maybe we should look at an alternate benefit. So let that thing slide through the system untouched, and you're better off, and you're getting faster reimbursement. Understand your contracts. One of the big issues in today's market is that you look at a fee schedule, meet your threshold, you sign the contract, all of a sudden now you're getting your claims in and you're finding that what you thought was 49% of UCR is actually 32. So understand when you get that contract, how's the insurance carrier going to pay you? Mostly all of them are leasing networks. So they may have leased a network with a much lower fee schedule. And if you're in both networks, they will pay you off of the lower fee schedule. So understand when you're working with a carrier, how they're using leases, and are you given the ability to opt in or opt out of having your going on the lease. So really understand your contract. When I say mindful expansion, what I mean is if you're looking to expand your practice, understand, when we get back to supply and demand, where's there a gap?
Mhm.
So, everybody looks at the panhandle, you can't have, everybody wants offices in the panhandle. But, look at, if you're going to expand to where there's an access issue, and then you're guaranteed immediate patient flow and the ability to negotiate that contract. Credentialing is so important. It could take 120 days. Don't forget to put the DEA in. Don't forget to do primary source verification. Again, once and done, so that your new provider can get chairside quickly. If you have a large enough group practice, I would definitely recommend going delegated, where your doctor becomes credentialed day one of hire. And so you're limiting the amount of time waiting to be approved. EFT, electronic funds transfer, you get your money right away. For those doctors that are looking to get paper, a lot of the carriers now, instead of sending you a check, are sending you credit cards. Not sure you want to, why, or if you want to work with the credit card, which is fine, but electronic funds transfer, that claim gets paid and your money's immediately put into your account. UCRs, again, make sure that, your UCRs are reasonable, because if you, just because you have a higher UCR, they're not going to pay you more. And you don't want to scare away any new cash patients that might be coming in. Understand what's going on around you and adjust your UCRs accordingly. Specialty, there is a huge need, always has been, for specialists.
Mhm.
And we don't even, pedodontists anymore are almost looked at as, and I hope there are no pedodontists in the audience, I don't mean disrespect, but the carriers look at it kind of almost pedo as a GP process versus endo, perio, and oral surgery.
Mhm.
So you have the opportunity to bring a specialist in, even if he comes in once a month, once a week. I always believe you never let a patient outside your door. You keep that patient in and offer as many services as you can. Make sure your billing is correct, and that there's no errors. Differentiation. If there's 25 doctors within 5 miles of you on the network, what makes you different? What's going to allow you to get in the door with the insurance carrier to say, here's where I'm different, and here's why you should work with me. Here's why my reimbursement should be different. So think about the differentiation. Membership plans. Membership plans are ideal, and that's where you have your own discount plan in your office. And what that means is that a cash patient can come in today, and I don't know any dental office where any cash patient walks out paying 100% of UCR. They're given a cash discount, a Thursday discount. And so if you put a plan together, and there are a million organizations out there that can do it for you, is that when the difference is, I'm a cash patient, I come in, I buy this membership plan from you for $100 a year. That's not the issue. That's not the money. Where it is that now I'm locked in. If I want this discount, I have to keep coming back to you. And so think about it that way. It's more around retention of your cash patients than it is building revenue. Teledentistry, we learned through COVID that this really does work. Here's, what do you offer? Look at who your patients are. And I'm seeing more and more proposals coming in from employers. And on their proposals, they're asking, do you offer teledentistry? Do your providers offer teledentistry? And pretty soon you're going to wind up seeing on the directory, you're going to see those things that are offered. So if you offer teledentistry, it will show on the directory. And not me, because I'm so old school, but my 32-year-old son will go, yeah, that's a dentist I'm picking, because I don't have time to go in. I just want to call So kind of think about those things to the practice. AI, artificial intelligence, while I think, if for the smaller offices may not be ideal, but understand what it does and how it does. There are many insurance companies in the last year and a half that have added AI. And what that does is, there were guidelines about, pockets before they would pay for perio, whether it's 5 millimeters, you can tell I'm not a dentist, or more than they pay. What AI does is it gets down to where, it's not just me saying what it is, or just sending in an x-ray that's not clear. So they're going to be able to really look at how they pay claims and when alternate benefits need to be applied. The other thing from a plus from a dentist perspective is that it also helps with undiagnosed treatment that may pass. And so, we talked about the plans. Look at not only when you're looking at how, what your threshold is, how many members are coming in from that plan. I always like to look at what's my production per visit. So am I getting $235 every time, XYZ insurance carrier comes in? If you can't be adding new plans and doing all of this, I would look and say, how can I get that 235 to 375? So look at increasing your production per visit, and that would help on revenue as well. And then the question marks that I left on the arrows are, what do you think you can do, or what can you add to that diagram that can help build the practice, differentiate yourself with the carriers, and be able to make it work in your office?
Oh, Amy, on
Yes.
that, we're almost through our time, and I feel like we could spend a couple of hours just talking about the content of this slide. It just, I think of so many questions, but we do have one question.
Yes.
Self-funded and federal plans are not required to follow state insurance laws such as fee capping or non-covered service laws, correct? That's the question. Comments?
That is correct. Now, again, you have to look at your contract,
Yeah.
the law, and then the law in your state. So the laws that I have seen on non-covered services were very general and broad and didn't call out specific plans or exclude specific plans. When it comes to federal plans, I would be very careful in looking at that contract, because there may be an exclusion that I hadn't seen in your particular state.
That's wise advice. It often seems like those do vary by state, even when it's a federal plan. I am so sorry. We have to start to close this down because I want to ask like 100 questions. But here we are at the end of this really informational presentation. And I wanted to remind us, but we still had a couple of minutes. We have got our next presentation that we will be sending out information on in about 2 weeks. Cash flow is king, revenue cycle management best practices. We're going to be building on Amy's superb presentation today to go further into revenue cycle management. So for those of you attending today, please join us on this next one as well. And then for contacting Hendrik, who is coordinating all of our presentations in this series, here is his contact information, and certainly feel free to reach out to him. Amy, we're down to like 20 seconds. Is there one word of advice that just totally pops out to you?
I would say that the days of just getting a contract in and signing them are gone. I would just say, make sure that you understand the contract, understand the wording, and especially around lease networks, understand what you're being paid and how you're being paid, and understand what you can and can't do for your patients.
Thank you so much, Amy. Thank you, everyone, for attending. Thank you, Hendrik, for being the moderator and bringing your insights as well. And to everyone who attended, have a lovely rest of your evening and join us on the next presentation.
Thank you, Andrea. Thank you all for
Thank you all.
joining.